This is Nastasia Walsh, NACO Program Manager, National Association of Counties. I'm going to be moderating today's webinar. Thank you for joining us. As you know, this webinar is part of Stepping Up, which is a national initiative to reduce the number of people with mental illnesses in jails. Stepping Up is a result of a partnership between the National Association of Counties, the Council of State Governments Justice Center, and the American Psychiatric Association Foundation. And we received generous support from the U.S. Department of Justice, Bureau of Justice Assistance, and other private sponsors for Stepping Up. So before we begin, I'll go over just a few technical details to make sure that everyone can view the webinar correctly. I know that many of you have been on these webinars before, and we appreciate it, but want to make sure we have a lot of new people who are joining as well, and want to make sure they know how this works. So this webinar is being recorded. It will be posted on the Stepping Up website for future viewing. You'll receive an email in the next few days with a link to the webinar recording. We also have included the slides in the Handouts tab if you want to follow along, and we'll also post the slides online with the recording on stepuptogether.org after the webinar. Also, to the right of your screen, you'll notice that there is a control panel, and in this panel there's a questions box. So you can use this box anytime to send us any questions or send us a message if you're having any sort of technical difficulties, and we can respond to you directly. And then during the Q&A session after our panelists, at the end of the webinar, I'll read the question on your behalf. If you want to have a better view of the presentation, you can click the small red arrow in the top left corner of that dashboard. Like I said, since we've already had a few of these calls this year, I don't want to spend a lot of time talking about what the initiative is. So if you don't know a lot about the initiative, I would strongly suggest that you look at the previous Stepping Up webinars on the Stepping Up Toolkit resources page at stepuptogether.org/toolkit in order to get more information, or please feel free to reach out to one of the folks on the last slide of this webinar, including myself, to get more information. We'd be happy to talk with you about that. Just a quick announcement that as of this morning, we have 364 counties across the country that have already started to sign on to the initiative by passing a resolution or a proclamation to support activities in their county to reduce the number of people with mental illnesses in their jails. So we're very, very excited to have all of you on board. If you go to stepuptogether.org, you can see a list and a map of all of the counties who have joined the initiative. And we try and update that map as often as we can to make sure that we've got the most accurate list of folks up there. If you think that your county has passed a resolution and you don't see your county highlighted on stepuptogether.org, just shoot over an email to us and we can make sure that we include you in that list as well. So now I'd like to introduce Ruby Kazelbash, who is the Associate Deputy Director at the Bureau of Justice Assistance at the U.S. Department of Justice, to talk a little bit about BJA's interest and involvement in Stepping Up. Ruby?
Thanks, Nastasia, and thank you so much to the national partners on this important initiative. BJA continues to be a strong supporter of the Stepping Up initiative, and we really believe that the community of counties that it supports and the resources that Stepping Up provides to that community of counties holds tremendous promise to make change in this area. I think that today's webinar topic is a really important one. I don't think that you can begin to plan for a solution until all the parties at that county table really have a handle on the extent of the problem, and this is really walking people forward in trying to do that problem identification and definition. So like you, I really look forward to hearing from our national partners today, as well as our county leaders, as they discuss what's worked for them. Thank you.
Great. Thank you so much, Ruby, and for yours and the Department of Justice's support of Stepping Up and the work that's happening in these counties across the country. So on today's webinar, like Ruby said, we're going to discuss key strategies for establishing baseline data on the number of people with mental illnesses in county jails. How we know that in order to reduce these numbers, counties really need to have sort of a clear and accurate understanding of the prevalence of people with mental illnesses and other behavioral health disorders in your jail. And so baseline data, really highlight where some of the best opportunities exist to reduce the number of people with mental illnesses in jails. And they also provide benchmarks against which progress can be measured. How do you know how far you've come if you don't know where you've started? So today we're going to hear from Dr. Richard Cho from the Council of State Governments Justice Center, as well as presenters from Athens-Clarke County in Georgia and Wake County in North Carolina. So I'll introduce all of the speakers as we go along. So first, we're going to hear from Dr. Richard Cho, who is the Director of Behavioral Health at the Council of State Governments Justice Center. Dr. Cho has worked for more than 15 years designing, implementing, and testing innovative housing interventions and policies to end homelessness, which we know is a big challenge for a lot of our counties on the call. Before joining the CSG Justice Center, he served as Deputy Director of the United States Interagency Council on Homelessness, where he oversaw the collaborative developments of policies to end homelessness across 19 federal agencies. And he served as the lead policy advisor on the effort to end homelessness among veterans and people experiencing chronic homelessness, as well as on the integration of healthcare, behavioral health, and affordable housing. He also served as the Director of Innovations and Research at the Corporation for Supportive Housing. So Dr. Cho, I'm going to hand it over to you.
Great. Thank you, Nastasia, and thanks for sponsoring this and holding this webinar. I also want to thank Ruby Kozlobash and BJA for their support to the Stepping Up initiative. Today's webinar is a part of a larger series that we've been using to help orient counties that have joined Stepping Up around the critical framework that we think is really needed in order to bring about a measurable reduction in the number of people with mental illness in jails. Today we're going to be talking about what I think is a really critical step and component of this effort, which is to establish baseline data. On the next slide, just wanted to remind you all that we've developed, working with our partners, a common framework for how we think counties can begin to tackle this issue. And that is a document that we refer to as the 6 questions document, which is available at the website that Nastasia mentioned. And one of the 6 components, in addition to having committed leadership, as well as identifying people with mental illnesses in jails through timely screening and assessment, is to have baseline data. As Nastasia mentioned, the starting point for any system improvements that your county needs to take in order to bring the number down is to know how many people today are currently in your jails that have mental illness. On the next slide, Stepping Up, I think, is really responding to what we've all been experiencing at the county levels as a growing crisis of mental illnesses in jails. We know, for example, that people with mental illnesses in jails are overrepresented. We think the prevalence of mental illness in jails is 17%, whereas in the general population, the percentage of people with serious mental illness is closer to 5%. And on the next slide, you'll see that we've seen as much as jail populations around the country have been declining over the last few decades. The growing experience in counties is that the number of people and the percentage of people with mental illnesses in jails is increasing. And so while jail populations are down, the population of people seeking mental health care and treatment in jails is increasing. I will say a lot of the data that we've been using to really provide an estimate nationally of what this problem looks like is old data. It's also, we think, somewhat of an undercount. And the reason is because in most jurisdictions across the country, we don't have a clear sense of how many people with mental illnesses are in jails. And that, I think, is really both the subject of this webinar, but I think the fundamental challenge that we're facing with tackling this issue, which is that it's hard to solve a problem that you can't size, and that we need to have a better count in every county in this country on how many people on any given day have a mental illness. I think, next slide, we included this quote from Secretary John Wetzel, who leads the Pennsylvania Department of Corrections. And I won't read the quote, but really included this because he so articulately put it so well that, for 20 years we've been talking about the problem, the growing crisis of mental illnesses in our jails. But what he says is that, for 20 years we talked about it as an issue that we didn't have a clear sense of, it was amorphous, and that we couldn't quantify. Issues don't get solved, he said, but problems do get solved. Problems are things that you can define, and our problems are things that you can quantify. And that's where we are with the crisis of mental illnesses in jails today. We need to move from it being an issue that doesn't have a particular size or is not quantified to a problem that we can size and quantify. And from there, we can actually begin to solve it. So that's why baseline data is so important. Again, if the core premise of stepping up is to reduce the prevalence of people with mental illnesses in jails, for example, can we bring that prevalence closer to what it is in the general population, then counties need to be able to have accurate and accessible data on the number of people with mental illnesses in their jails, and then they can measure their progress against that benchmark. What I'll be talking about today is just to provide a quick overview of what we think are the key process steps in being able to have that baseline data, as well as about the four key measures that we think are critical to be able to measure whether we're reducing that prevalence overall. And then I'll talk a little bit about some of the ways that that data enables you to make some strategic decisions about where to invest resources and efforts to make progress against that measure. On the next slide, we think really our kind of four key steps to being able to have accurate and accessible data on the number and the prevalence of people with mental illnesses in jails. First and foremost, there may be many counties across the country that have some kind of a mental health flag in their system. But that mental health flag might be based on a screening and assessment of mental illness that isn't aligned with community definitions of serious mental illnesses. For instance, some counties use a suicide screen, or some counties ask about whether people are taking medications. That is not necessarily aligned with the way mental health services eligibility for mental health services are defined by a state or community. So first and foremost, a recommended practice is to have a common definition of serious mental illnesses that is aligned with the way that states and counties and often the federal government defines eligibility for services for serious mental illnesses. Second, counties within the jails need to be using a validated mental health screening tool, and the idea is to make sure that you are screening everyone who comes into the jail, regardless of what led them to come to that jail. And then once people are screened positive using that screener, that there's a clinical assessment conducted by a licensed professional that conducts a longer-term follow-up assessment that's really able to understand what is the diagnosis and the types and levels of need within a person's mental health situation. Third is to actually record that, is to have a flag in county jail databases in administrative data that can actually record whether people have been screened and assessed positively for having a mental illness. And not only recording that, we hear stories everywhere we go around the country of counties being able to record that data, but then not having the ability to access that data, not being able to hit a button and produce a report on any given day of how many people have been screened and assessed positively for mental illnesses. That's what the next step is to record it and then to actually be able to access the data and not only access it, but to regularly track that number and actually measure progress against that. So those are the four basic steps, and we know counties are in different places with respect to being able to use these four steps. Again, some are screening and assessing, but not using a validated instrument. Others are screening, assessing, using a validated instrument, but don't have the data capabilities to be able to produce reports. And I think the critical thing is for if we can all work together to move towards where we have a universal screening and assessment based on a definition of mental illnesses that's aligned with state and county definitions, and that we're recording that data and also tracking it. On the next slide, we also think it's critical to be able to measure and track our progress based on four key measures. And so in addition to having the overall number of how many people with mental illnesses are in our jails on any given day, we also need to be able to track four other measures. And first and foremost, and these are the measures that really define a success and that frankly add up to that larger number of how many people are in our jails with mental illness on any given day. First and foremost, we need to track the number of people with mental illnesses that are booked into our jails, and then work towards reducing that number. Second is to shorten the length of stay, the average length of stay that people with mental illnesses spend in jails, and work to shorten that time frame. Third, we want to increase the percentage of people who are connected to care that have serious mental illnesses, into the community. And fourth, track and reduce our rates of recidivism among this population. Again, those four key steps for this data as well is to have a system-wide definition of recidivism. This needs to be collected electronically. We need to have baseline data also on the general population of jails, which enables us to compare how, for example, the length of stay for people with mental illnesses is longer or shorter than the general population. And then to have routine reports that we can look at and that county leaders as a collaborative can look at together to make sure that they're tracking progress. So the next slide really just illustrates this visually on how these four measures add up to the overall prevalence. The first measure of looking at jail bookings is frankly a measure of how many people are actually coming into the jails versus being diverted from the jails. Second, the average length of stay. If a length of time is longer for people with serious mental illnesses than it is for the general population, and the degree to which that length of stay is long overall means that on any given day we'll have more people with mental illnesses in our jails. Third, the number and percentage of people that are connected to care and treatment. We've done work in many counties across the country where looking more closely at that, we found that there's often people with mental illnesses who are not being connected to care as much as we thought, and can we close that gap? And last but not least, as we connect more people to care, either who are diverted from jails or who are reentering the community at the end of a jail term, can we reduce their rate of recidivism? And that's really where the improvement of programming comes into place. Let me walk through quickly in the next few slides how you would actually begin to measure these different actually use data to measure these four key outcome measures. First, in terms of the number of people who are booked into jails, the real main measure is really extracting the data point on the number of total and unique individuals identified as having a serious mental illnesses who are booked into jails. And that's really just a critical measure of how many people are flowing into the jails. In addition, you can look at how many folks with mental illnesses were diverted from jails by law enforcement, and that gives you a sense of whether the volume of people who are being diverted is actually large enough and enables you to think about whether there's efforts to scale up law enforcement-based diversion. In addition, you can compare the number of people booked into jails with those between those who have serious mental illnesses and those who don't have a mental illness. And then look at some demographic, legal, and criminogenic risk differences to see what are some of the drivers of why people are being booked into jails who have a mental illness. Second, in terms of the measuring the average length of stay, really this is a measure of how long people with mental illnesses are staying in jails on average, and we think it's critical to look at that by release type. For example, on a monthly basis, a report can be pulled of, on average, how many people who have a positive mental health flag based on, again, a validated screen and assessment, what is the length of stay on average that they're staying in jails, and by different release types, pretrial versus sentence, etc. In addition, some other submeasures that can be looked at are whether people are being screened as low, medium, high based on their pretrial risk factors, as well as comparing the average length of stay for people with serious mental illnesses versus the general jail population. One of the things we've seen in some of the jurisdictions that we've worked in is that the pretrial length of stay on average for people with mental illnesses is often twice as long as people in the general population. And that can be for a variety of factors. It could be for challenges with managing the population within jails, where conducts mean that people are disciplined and therefore have to spend longer periods of time in jail. It could be about court processes and whether courts are able to process these cases quickly. It could also be about pretrial and bail practices and whether those things are affecting people's length of stay. For example, people with serious mental illnesses who may be very low income or on disability income, but are being charged bail and have the inability to pay will end up spending longer periods of time within jails. The third measure is on the percentage of people, on the next slide, of people with serious mental illnesses who are connected to treatment. And there's really two measures here. One is looking at the percentage, so looking at the number of people with serious mental illnesses who are connected to treatment versus the number of people with serious mental illnesses who are not connected to treatment, and looking at that overall percentage. Second, you also want to look at the percentage of people with mental illnesses that are connected to community supervision and or treatment programs by release type. This again can be measured and compared to connections to care for the general population, bookings for the general population, and also looking at demographic and criminogenic information. And the fourth measure, the next slide, is the rate of recidivism, which I think there's many different ways to look at recidivism, and we think that there's really three critical ways to do that. First is to look at the percentage of failures to appear or rates of rearrest among people with serious mental illnesses, as well as rearrest for post-jail sentences, sentence populations with serious mental illnesses. Second, you can look at people who are returning to jail due to technical violations versus new criminal charges. And then last, looking at of the people who are in jails, the number of prior jail admissions, which gives you a sense of how many people are actually repeat jail users, and frankly, also who might be frequent users or repeat high utilizers of their jail. And again, that also can be compared for people with serious mental illnesses versus people who don't have mental illnesses to understand what are some of the drivers affecting recidivism. So on the next few slides, I'm going to talk a little bit about a kind of case study for how we might use these four measures to begin to think through what are the strategic decisions for where we can make system improvements. So take a county, for example, that is able to track their progress against these four measures. And let's say that on the first day of the month, they find that there's about 100 people with mental illnesses in their jails who've been screened and assessed as having mental illness. In addition, during that month, another 100 people become booked into the jails, which means you'll have now 200 people who were in jails on the first day of the month, as well as 100 new people who've been booked into the jail. The average length of stay in jail is, let's say, in months is about half a month or 2 weeks or so. And so by the end of the month, you're going to have about 100 of those people who were previously there, about 50% of them will still be in the jails. Then you're connecting 20% of the population with serious mental illnesses to treatment and services, and at a rate of 20% recidivism, that leaves you with 80 people. And finally, looking at the overall rate of recidivism is about 60%. When you add all that up, you end up having a monthly jail census of about 252 people with mental illnesses in jails. Next slide. So let's say that this particular county is able to look at what are some of the drivers of why 100 people are being booked into our jails that have serious mental illnesses. And they begin to ask themselves questions like, do we have effective police mental health collaborations that are working to better divert people with serious mental illnesses from arrest and connect them to care? Do we have crisis mental health services, a crisis diversion center, for example, that's able to respond to calls for service, giving police and law enforcement agencies an alternative to being able to arrest them or send them to the emergency departments? Third, let's look at what percentage of people with serious mental illnesses are currently under supervision at booking, and are there ways that we can affect the probation practices or parole practices and include a better partnership between law enforcement, communities, corrections, as well as behavioral health. And last, to what degree are the folks who are being booked into the jails really represented among a high subset of high utilizers who are really driving up those jail bookings? They can also look at, in terms of the average length of stay, what's really driving that long length of stay. 2 weeks actually is not a very long length of stay, but they could ask questions like, do we have pretrial programs that are able to systematically identify people with serious mental illnesses, consider them for jail diversion, and divert them to a combination of services and or supervision? Second, do the courts have a partnership with behavioral health providers, with families and advocates that are able to more quickly and appropriately review and process cases involving people with serious mental illnesses? Third, are we looking at our bail practices and whether the way that individuals are being charged bail is actually contributing to their length of stay in jail when that could be avoided or reduced? And fourth, are we training correctional officers within jails in crisis intervention to help avoid the kind of infractions that sometimes contribute to longer stays? Third, with regard to the percentage of people connected to treatment, looking at that data point enables you to start asking questions like, have we quantified the unmet need? Do we know exactly what precisely is the gap of people who are not being connected to care and treatment? Second, are we actually tailoring the types of care and support based on the assessed need and assessed levels of risk, and making sure that people who are high need and high risk are being prioritized for more intensive services. Third, do we know what types of additional capacity is needed, not only in terms of crisis diversion services, but also the longer-term treatment and supports that often make it possible to not bottleneck the crisis services, as well as make sure that people are connected to the appropriate level of care so they don't come back to jails. Are we looking at housing needs as well? And last, do we have not only available services, but do law enforcement officers, do court-based professionals and judges and jail personnel know how to navigate and access those community-based services? Is there a coordinated way that those services can be accessed? And fourth and finally, this particular county, looking at the recidivism rate, can start to ask questions like, are we targeting supervision, interventions, and assistance based on assessed levels of need and risk? Are we looking at specialized strategies for people who might be coming back to jails due to technical violations? Are we looking at specialized strategies for people who might be coming back to jail due to failures to appear or things like open warrants? And last, are we holding various programs accountable for making sure that their performance and frankly their funding could be based on whether they're successful in terms of reducing recidivism, and do we have a process for reallocating resources based on those outcomes? So this particular county was able to look at these system improvements, and they were able to actually cut the number of people newly booked into jails by 50%. So there's half the number of people who are coming to jails, and that could have been through law enforcement-based diversion programs, for example. They were able to cut the average length of stay in jail by half, or by rather half a week. So they were able to cut it from 2 weeks to a week and a half. And they were able to increase the number of people, so connecting 10 more people to treatment and services per month than they were previously, and last cut their rate of recidivism. So you saw their number go from about 250 people on any given day, any given month, who were in jails who had mental illnesses, down to 134. Really, I present this as a way to just illustrate how the kind of strategic decisions we make and the way that we can measure our progress based on clear metrics really enables us to bring the overall census of people in jails who have a serious mental illnesses down. So with that, I'm going to turn this back to Nastasia, and certainly if there's more questions, you can contact us through the Stepping Up centralized information, or there's my email address as well. Thanks so much.
Great. Thank you so much, Richard. We appreciate it. And we know that data is obviously something that, most of the folks on this call are really struggling with, and appreciate, sort of sharing a process for how this happens, recognizing that, a lot of counties already have their own processes too that are sort of very similar to what's happening here. And, I think our next two counties, are doing things and calculating their baseline data very differently, but still getting some really interesting results. And so I want to, quickly sort of jump into our next set of speakers here. I want to introduce Evan Mills and Laura Alexander to talk about their processes in Athens, Clarke County in Georgia. So Evan Mills is the Director of Business Development at Advantage Behavioral Health Systems. And in this role, he's responsible for the initiation and development of grant-supported programs, as well as ongoing grant management activities that support program design and evaluation of their service delivery outcomes. He also sits on several local and state nonprofit boards whose missions coincide with the underlying foundation of Advantage's purpose, which is to provide support to those most in need. And then prior to joining Advantage, Mr. Mills worked for Athens Clarke County government for 10 years, administering federal grants to local nonprofit organizations and coordinating the continuum of care for homeless services within that region. And joining Mr. Mills is Laura Alexander, who is the grants manager at Advantage and has been spearheading the data work happening in that county. Prior to coming to Advantage, Laura worked in various capacities to help communities develop programs and policies to improve the health of the most vulnerable populations. She has longstanding interest in the intersection of criminal justice and health, and she's volunteered in a minimum security prison for over 5 years. So Evan and Laura, I'm going to pass it over to you.
Thank you, Nastasia, and good afternoon, everyone. My name is Evan Mills, and I, along with my colleague Laura Alexander, will be discussing all of the wonderful things we've been doing here in Little Athens, Georgia. In this slide is a picture of our fine city, which centers on our city hall and was taken from the top of a parking deck. Now, I would love to take credit for this picture, and I might even get away with it in this setting, but that would be wrong, so I'm not going to do that. Next slide, please. Here in this slide are some brief statistics on our community. I would like to point out that we are the smallest county geographically in the state of Georgia. It should also be noted that we are the 7th poorest county out of 159 counties in Georgia. Our current poverty rate is 38%. However, this does include our student population, but when you take out the students, our rate drops only by 10 percentage points. So we are also the home of the University of Georgia, go Dogs. Our local economy is largely service-based. We have a high poverty rate and a low unemployment rate, which can translate into many job opportunities that pay low wages. The university owns a significant amount of land in Athens-Clarke. We also have a very high number of churches and nonprofit organizations in Athens. I'm saying all this to say that we have a very limited tax base, which combined with high poverty and low wages creates a mix of high needs and limited resources to address those needs, which is why we have had to be very creative in our approach to new initiatives. Next slide, please. Laura and I are on this call representing not only Athens-Clarke County, but also Advantage Behavioral Health Systems. Advantage is the local community mental health agency that is chartered with the state of Georgia to be the safety net provider for those with behavioral health disorders. We serve the 10-county region of Northeast Georgia and are based in Athens-Clarke County. We serve an average of 10,000 people per year. Approximately 4,000 of those people reside within Athens-Clarke. As the safety net provider, our target population consists largely of individuals who lack other basic means of support. 97% of the folks we serve fall below the federal poverty guidelines, meaning that in addition to behavioral health disorders, they typically have other environmental barriers as well, such as unstable housing, or underemployment, lack of reliable transportation, and in a lot of cases, a history with the local justice system. Through partnerships and other grant-funded initiatives, we provide a continuum of services meant to provide a holistic approach to treatment. I think it is important to think of Advantage as not just a provider of behavioral health services, but a provider of support services to individuals with behavioral health disorders. Next slide, please. The Athens-Clarke County Jail has been a key partner in this entire process. They graciously opened their record system to us, and without their cooperation, we would not have been able to gather the data we needed to drive our local policy decisions. Recently, they have expanded their facility and have partnered with Advantage on a recent reentry grant proposal. The average daily population hovers around 400 to 450 individuals. The current jail population is approximately 68% African American and 30% white. Women make up approximately 12% of the overall jail population here in Athens. The average jail stay is about 40 days, which is reflective of individuals who have not bonded out within the initial 72 hours. From a volume perspective, approximately 9,000 individuals are booked into jail on an annual basis. Can you go to the next slide, please? So, in 2015, Athens-Clarke County applied for and was awarded a Justice and Mental Health Collaboration Planning Grant. Previous to this opportunity, a group of us had been meeting on an informal basis at the behest of a local judge so that we could develop ways to better coordinate services. When this grant announcement came around, we jumped at the opportunity to use this grant to formalize our planning activities and develop a data collection process that could help us drive local policy to implement effective programs for our target population. The core collaborative group that led our planning initiative was made up of representatives from Advantage, from Athens-Clarke County Jail, ACC Police Department, our local court system, and the University of Georgia's J.W. Fanning Institute, with whom we have contracted with to lead the planning efforts. I think it's important to mention that before we started this process, we already had buy-in from each of the represented agencies within this core group. We knew problems existed within our system, and we knew we needed local data to support our arguments for resources that will help us address the needs of individuals continuously cycling through our systems. Next slide, please. So the key objectives of the JMHC Planning Grant included an environmental assessment of our local system that includes a process analysis of all our provider agencies who might be involved with an individual who is cycling through our justice system. Secondly, an analysis of the population of focus, which includes three basic elements: demographic information, diagnosis trends, and criminal history, focusing on frequency and nature of the crime. This was to help us further define our local population so that we could more effectively develop programs that would address their needs. And finally, we would use the recommendations provided from the results of these assessments to formalize partnerships among key providers and involved organizations, and to justify policy and programming that addresses the needs identified. Next slide, please. This diagram was developed by UGA's Fanning Institute as part of their overall assessment of our local justice system in its current state. This was part of the first objective outlined within our JMHC planning process, and I thought it would be nice to include a visual representation of the flow of individuals through our system. And if you could imagine all of the opportunities for duplication of services, miscommunication among organizations, and places where an individual might fall through the cracks in our system, particularly if he or she has a severe and persistent mental illness. As you can see, the different sectors within our system are color-coded and include all partners that an individual might touch when cycling through our system. The diagram includes first responders, emergency health services, mental health services, ACC jail, and local court systems, including our specialty court programs.
Next slide, please. This is Laura, and as it was mentioned, I kind of spearheaded the data collection process. And once we got that exhaustingly busy map that Fanning created, we knew that it had answered some of our questions about our system and how people cycle through it, but it didn't answer all of our questions. We still needed to get specific numbers of people and how they move through the system. So in order to do a deeper data dive, we identified a 3-month period and decided to look at every single arrest record for that time. The jail staff assembled a list of every person booked into the jail from October through December of 2015 and sent me their names and birthdays. I then spent about 3 weeks and looked up every single name in our electronic health record at Advantage. I've made notes of which individuals were Advantage clients, what their diagnoses were, when they first began services with us, and any other pertinent information. I then took my list of our shared clients back over to the jail and was able to research their criminal histories using the jail's database. Next slide. Before I get into our results, I want to say a few more things about how we conducted this research. So initially, we had assumed that our university partners would be able to do the deep data dive. But as we began planning how it would actually work, we realized that as the behavioral health provider, we were the only ones who could actually do the research because we guard the protected health information that is our client list. While jail records are public, we had to take the initiative. We also wanted to choose a study window that was truly representative of our community. So we chose October through December because it included months with and without home football games and months with and without the university being in session. Both of these factors greatly affect the dynamics of our town. Doing all this research was incredibly time-intensive, but not directly expensive. I think it took me about 5 weeks to collect all of this data throughout the course of a year. And my CEO just generously allowed me to do that because he values this project. Likewise, I was able to do this work because as an Advantage employee, I have access to our electronic health records, and I received enormous support from our jail commander to use theirs. He allowed me access to a computer in the jail and personally trained me on how to use his database in order to research the criminal histories. Finally, it was important to be flexible when doing my data collection. I initially did not collect any information on the types of charges because I didn't think it was relevant and I assumed it would be too time-consuming. But after we reviewed the data I had collected, I knew we had to look at the types of charges in order to plan the most effective diversion intervention. This meant going back to the jail to collect more data, but it was worth it. Next. Okay, so we found that of the 1,842 people that were arrested and booked in the jail during the study window, 706, or 38%, were Advantage clients. So 38% represents the absolute minimum percentage of the jail population with a behavioral health diagnosis, since it only counts our clients. Of those 706, 65% had a primary diagnosis of mental health, while 35% had a primary diagnosis of addictive disease. About half had co-occurring diagnoses. This means that on average,
7.7 Advantage clients get arrested every day in Clark County alone. This is a very sobering fact for us to realize. Next slide. When looking at their criminal histories, we found that 91% of our 706 had been arrested multiple times. The average number of lifetime arrests is 12.7, with the range going all the way to 108 arrests. Altogether, the 706 clients arrested during the study window have been arrested almost 9,000 times. The average length of stay, next slide. The average length of stay in jail for our clients is 22.7 days. And we calculated recidivism for this particular study by looking at return to jail in the first year, the first calendar year following their study period, and found that 53% have returned to jail at least once in 2016. Next slide. We compared the criminal histories of our clients with the 1,100 individuals arrested during the study window who are not our clients and found stark differences. While 91% of our clients had multiple arrests, only 68% of the comparison group had multiple arrests. Likewise, the average number of lifetime arrests for our clients was more than twice that of the non-clients, and the average length of stay was almost 3 times as long. The recidivism rates also differ, as only 36% of the non-clients returned to jail in the year following their arrest. Next slide. As I mentioned earlier, I realized we needed to examine exactly what charges our clients were being arrested for. We chose a random sample of 250 clients out of the 706, and I looked up all of their charges for a 5-year period. Those 250 clients amassed over 2,700 charges during those years, and as you can see, most of them are parole and probation violations. This is crucially important information for a variety of reasons. First, it highlights the need for further collaboration with our partners in the Department of Community Supervision, but it also negates the stereotype that our clients are dangerous, violent people. Next slide.
So the really cool thing about all of this data is that it is ours. The individuals involved in these assessments live in our community. The providers and systems that are being evaluated are local and directly affect us. Up to this point, we would quote state or national statistics and use anecdotal evidence to justify our need for an effective response to these issues. Now with this data, we have a little bit more quote-unquote firepower to use locally and help drive policy. As a result, locally people are starting to listen a bit more. On April 4th, our mayor and commission passed the Stepping Up resolution committing our local government to put in measures and resources to address the prevalence of individuals with mental illness involved within our system. We have applied for 2 federal grant opportunities that, when combined, will allow us to address all points on the sequential intercept map that range from jail diversion to reentry planning. Next slide, please. The Athens Clarke County Police have recently created a specialized crisis intervention unit headed by a senior police officer. This officer, Robbie Cochran, has been assigned to directly coordinate response to individuals with mental illness, to lead training across the police department in crisis intervention and mental health first aid, and develop a tracking method that will provide ongoing assessment to the extent of individuals with mental illness involved in the system. Next slide, please. The Crisis Intervention Unit began tracking this information in January of this year. To date, they have recorded 371 interactions with individuals that were involved with a mental health crisis. These encounters involved 248 individuals. Illustrated within the graph is a breakdown of the nature of the response. So as you can see, 39% of the individuals involved were offenders and 27% were victims. Next slide, please. The Athens Clarke County Jail is currently in the process of instituting the correctional mental health screen for male and female for each individual booked into jail. This will allow jail staff to better identify individuals who may need behavioral health supports and will better inform coordinated reentry planning. They are also in the process of adopting a new system-wide records management system which will allow them to collect and analyze prevalence and criminal history data and better coordinate services with other criminal justice organizations as well as other involved health providers. Next slide, please. So to sum up, I would like to point out that the key driver in our processes to date and moving forward has been data. We have been able to paint a very specific, informative, and in some cases eye-opening picture of our local justice system. This has enabled us to get a more productive conversation with local policymakers that will hopefully allow us to point resources toward directly addressing the needs and barriers of justice-involved individuals with a severe mental illness and or substance addiction. I would like to thank you all for your time and interest. It has been a pleasure presenting to you. Here's our contact information. If any of you have any additional questions or would like to discuss any points of information further, please feel free to contact us. Thank you so much. Back to you, Ms. Dasha.
Great. Thank you so much, Evan and Laura, for that presentation. I think it's really cool the way that you, were able to use that data and sort of see the sharing, what you're allowed to share and what you're able to do with the data that you have. And Laura, thank you for looking at all of those records. It sounds like a lot of work. So thank you both for sharing what you're doing there. So our final two speakers, I want to introduce Sarah Warren and Dr. Sarah Desmarais to talk about projects happening in Wake County, North Carolina. So Sarah Warren is the budget and management analyst for the Wake County Sheriff's Office, where she provides analysis and support for a variety of functions, including budget, finance, human resources, and technology. Over her 4 years at the Sheriff's Office, Sarah's worked on projects that seek to improve jail services and inmates' interactions with the criminal justice system. She also co-chairs the Wake County Mental Health and Criminal Justice Advisory Committee and has facilitated a partnership with SAS Analytics using data to identify high utilizers in Wake County in an effort to divert them into services rather than jail. She has also worked as a budget analyst in Fairfax County in Virginia and with Wake County prior to serving at the Wake County Sheriff's Office. So welcome, Sarah. And then Dr. Desmarais is an associate professor and coordinator of the Applied Social and Community Psychology program at North Carolina State University. Her program of research lies at the nexus of public health and public safety. She has more than 80 publications on behavioral health assessment, risk assessment, and violence, and has held more than $3 million in grants from agencies including the National Institute of Health, the U.S. Department of Justice, and has trained and consulted for mental health and criminal justice agencies worldwide on the implementation of assessment approaches and other evidence-based practices in correctional settings. She also sits on local, state, and national advisory committees on these issues. So we'll say Sarah and Dr. Desmarais, I'm going to hand it over to you.
Great, thank you. This is Sarah Warren with the Wake County Sheriff's Office. I'm going to introduce you a little bit to the situation in Wake County and then hand over the rest of the presentation to Dr. Desmarais to talk about the meat of the findings that we have. You could go to the next slide. This is just to orient you on where we are in North Carolina. We are centered in the state of North Carolina in the RTP region, which includes Wake County, Durham County, and Orange County, for those who are familiar with UNC Chapel Hill and Duke University. We are in close proximity to them. Next slide. Wake County is home to the state capital of Raleigh and 13 other municipalities. We have just over 1 million residents, rivaling Charlotte-Mecklenburg for the largest metro area in North Carolina. Due to our proximity of universities, we have a lot of resources here, including North Carolina State University, Duke, and Chapel Hill. And we're a big government center since we are the capital county. Next slide. To give you a little bit of information about our history as it pertains to this project and the subject matter with which we're discussing, our current jail population for this past fiscal year is around 1175. Our maximum capacity is 1572 across 2 facilities. We do have a 3rd facility which is sitting vacant at the moment just because we simply don't need it. Our population, as indicated previously, in national trends, has declined over the course of the last several years. And we opened up our newest phase of our detention center in the spring of 2012. And that's also around the same time that Wake County began its divestiture of mental health services. Wake County was one of the last counties in North Carolina to divest mental health services in North Carolina. which meant that we moved away from a local management entity model of providing mental health services through the county to a managed care organization where that's more of a private provider. Additionally, the state closed the mental health hospital, Dorothea Dix, which was located here in Raleigh. It had a several hundred bed capacity, and that facility closed, and the function of the state mental health hospital moved about an hour away from us to I believe it's a 16 to 24 bed facility. So you can see the big shift in how we're providing mental health services, not only in Wake County, but in the state of North Carolina. As a result, the Wake County saw a big increase of those with serious mental illness in the jail population because their services in the community were disrupted. A lot of times they were left homeless, without medication, access to services, and we were seeing them on our streets. And then they were subsequently arrested for low-level offenses, trespassing, drunk in public, and they showed up in our jails. In 2014, we were awarded a SAMHSA grant to perform a sequential intercept map for our system, helped us understand how our system works with mental health in the criminal justice system and how individuals cycle through it. In 2015, we formed the Criminal Justice Mental Health Advisory Committee, which is taking some of the findings from the sequential intercept map and applying them to break the cycle of recidivism in our criminal justice system and address other issues as they pertain to caring for those individuals in our jails with mental illness. In 2016, not only did we join the Stepping Up initiative, but we also became a member of the White House Data-Driven Justice Initiative, working to use data to break this cycle of recidivism. And that has led to our project with SAS and this project with NC State that we're here to discuss. Next slide. This is just the Wake County Detention Center. This is our newer facility that opened up almost 5 years ago. Next slide. What really became the crux of the problem for us was the county kept pouring money into this problem in the jail. We have increased our allocation to our MCO by more than double, to a total of $1.3 million, just to provide mid-level services, licensed clinical social workers, caseworkers, peer support, to help these individuals. And we've not really seen a shift in individuals coming into our system, our jail, and in the criminal justice system, and thus getting connected to services and breaking that cycle. We've also increased the funding that the county allocates for psychiatric services by more than double. Provide weekend coverage, overnight coverage, and we've also increased our funding and staffing levels for specialty housing units just to address these individuals and provide them with a different level of care that they require as they're in our facility. Next slide. Because of all of these factors, we decided to engage with NC State. The MCO, because of HIPAA protection, is unable to share data with us unless there is client consent. So it makes it really hard for us to understand what our population looks like. And with working with Dr. Desmarais at NC State, we tried to understand what could we use, what tools we could use, begin to understand through data what our population looked like, how many people in our jail actually had a mental illness or at least came in with symptoms of a mental illness. And so that's when we decided to begin looking at our brief jail mental health screen, which used to be required by the state of North Carolina. We are still using it to identify symptoms at intake. And we wanted to use that to begin to see what our population looks like as they come in the door. We then wanted to take what data we could find to identify strategies to help serve them better while they're in our facility, help inform our detention officers who have to work with them on a daily basis, provide appropriate housing for them, and start that process of intervening with them while they're in our facility to access resources in a more efficient and productive manner. We also understand that we are probably missing some key factors that help us understand their risk and their criminogenic factors, which we hope to use this data to implement some additional strategies to screen for some of those factors. With that, I'll turn it over to Dr. Desmarais to talk about the findings.
Sure, next slide, please. So just briefly, we used any clinical and administrative data that we had available to us. So we had information on demographic characteristics, what the booking charges were and release dates. We were drawing the mental health symptoms from the Brief Jail Mental Health Screen, and then we're also in the process of integrating some of the physical health data in there as well, but I won't be talking about that today. Next slide, please. So just to get a sense, this is the prevalence of symptoms at intake across individuals booked during a one-year period. And so we can see here, generally speaking, that there's relatively low levels of individual symptoms. So for those symptoms that would be most associated with severe mental illness, we're typically under about 2%. And then we see higher rates, about 5% reporting symptoms that might be associated with depressive disorder, and then about 13% who are currently on medication and close to 10% who have a history of hospitalization. And so using those Brief Jail Mental Health Screen items, we were then interested to see whether or not there might be clustering of individuals as a function of symptoms. So next slide, please. Well, unfortunately, you can't see this one that well. So could you go to the next slide? There we go. This one's a little better. So essentially what we found is about 90% of people coming in did not seem to be presenting with symptoms of serious mental illness. We had about 5% who we would categorize as presenting with what we called managed mental illness. So there was a history of treatment. They were currently on medication, but they weren't presenting with any significant symptoms at this time. And then that remaining class of individuals were split between individuals who seemed to have symptoms indicative of mood disorders, and so combinations of sort of manic symptoms and depressive symptoms, and then also about 1% who really showed up to us as looking like they had untreated psychotic symptoms. So going to the next slide, please. We then ran a series of analyses just to get a picture of what these groups looked like, and we did find some differentiation in terms of their demographic characteristics. And sort of in the interest of time, I won't go into the details, but they often played out in the ways that we would think, and so homelessness associated with higher rates of mental health symptoms, higher rates of symptoms in women, and also our older inmates. With this set of data, we did not see any differences in the charge levels across these different groups, and so that's something that we're in the process of digging into further. Next slide, please. So for us, this sort of pointed to a few areas of strategies around perhaps triaging or allocation of resources. And so those that were coming in, for example, on medication, these seem to be individuals that could do with a check-in very quickly, but they were pretty stable. And so these were people that we would want to see quickly and then make sure that they're doing well as they continue in jail. We also saw some others regarding some evidence that there might be heightened violence or suicide risk as a function of these subgroups. And then also some groups of individuals for whom we might want to consider special classification. So for example, those who have suicide ideation potentially associated with their mood disorders, or also those individuals who had the psychotic symptoms and might be exacerbated by being placed with other inmates. Next slide, please. So in the short term, we're continuing to dig into the criminal justice data, and we're in the process of looking at the charges, both in terms of the severity and the level of the charge, the length of, or sorry, the number of charges, the length of stay, and the number of times they're booked associated with these different subgroups. And then down the road, we hope to look at the intersection of mental health, substance use, and physical health data. It also became clear that we seem to be under-detecting symptoms at intake, and so we are looking at strategies to add additional screening items to be able to tap more into psychotic symptoms, symptoms of anxiety, and post-traumatic stress disorder, and to think through possible points for interception and strategies for intervention. Next slide, please. And so the sort of culmination of this project is going to be about some recommendations. One thing that came clear for us is that this is only the picture at intake and not the picture as inmates continue through their stay within the criminal justice system. And so one thing we've talked a lot about is the need for readministration. Another thing that we've talked a lot about is the need for that follow-up assessment that's been talked about earlier. Currently, everybody is getting screened at intake, and it's less consistent as to whether or not people are receiving follow-up assessments after they're referred to mental health services. And then our long-term goals also include taking a look at costs and services associated with these different groups, and then to try to come up with strategies to sort of implement resources and mechanisms through the reintegration or the reentry process to ensure that they do show up at services once they're released. Next slide, please. Oh, and that's it.
Great. Thank you so much, Dr. Desmarais and Sarah. We appreciate it. I think, it's interesting to see the very different ways that these two counties have been going about looking at their data and establishing some baseline data and getting more information about their jail population. So appreciate both of you, all of you, all four of you, and Richard being on the call today. So we do have some time for questions, and we've already been getting some questions in. So if you do have a question for any of our speakers, please feel free to type them into the questions box on the right, and then I'll ask them aloud to the speakers. And if we don't get to your questions today, I would strongly encourage, and I would strongly encourage you anyway, to join all of us and those presenters on the network call, which is next week on Wednesday, May 17th at 2 p.m. Eastern. So why don't I kick it off, since we've already got some questions in for folks as these are coming in. Richard, a question came in during your presentation, during the first, when you're talking about the 4 key measures for reducing the number of people with mental illnesses in jails, you talked about tracking the number of people who are booked into jails, and you talked about tracking the number of people who are diverted. And so the question that came in was, how do you track those who are diverted from jail? And so interested in hearing your thoughts on that.
Yeah, and of course, the answer is going to be it depends, and part of that is because it depends on who's doing the diverting. In some communities, there's a focus on law enforcement-based diversion, and that's a data point. To be able to track that is data you're going to ultimately need to get from law enforcement agencies. The extent to which you can actually, look at, and there's often multiple law enforcement agencies within any particular county, so looking at all their this is really data points that each of those law enforcement agencies need to track in terms of the number of calls they get involving people with a mental health situation and how many folks are diverted. It's really disposition data at the law enforcement agency. In other jurisdictions, you may have a pretrial, you may have other kinds of diversion programs, and so, for example, in the courts, and so some of those data points may. I guess the answer is ultimately it depends, and it depends on who's doing the diversion that data comes from.
Okay, all right, great, thank you. Laura and Evan, we had a question that came in during your presentation too. So in addition to the HIPAA considerations, did you all have to work with an IRB at all to proceed with any data collection? And you know, maybe Dr. Desmarais and Sarah, maybe you all want to answer that too, but maybe we'll start with Laura and Evan.
We chose not to because we were collecting this information not for publication, but really to figure out how we as agencies can do a better job of serving these clients.
And at Wake County, for this particular project, all the data that we gave Dr. Desmarais was de-identified. However, there is an existing IRB, I believe, with the county and NC State for this purpose. However, the information that was provided, because there's no PHI and the Brief Jail Mental Health Screen is not considered a diagnostic tool, it wasn't necessarily required.
And I can say that we are excited about that moving forward, that since our jail will be doing a similar screen, they will have access to the same kind of data and we'll be able to share it widely throughout the community.
Okay, great. Thank you. Thank you both. So we had another question come in for Clark County. Did you have to get consents from the clients when you send the list of your clients back to the jail for additional information? I'm asking, I'm reading this. I'm asking because this question, as a behavioral health agency, it's challenging for us to find a way to share information with law enforcement agencies. And it sounds like you didn't necessarily share the information about your clients with the jail, just got client information from the jail and then match those up, right? Could you maybe respond to that question?
Exactly. So I took my list of client names on my computer over to the jail, and then once the jail commander showed me how to use the system, he left the room, and then I looked up all of our client names into his database and then entered the information back into my computer. So at no time did I disclose to him or anyone else in this project the names of our clients to keep them protected.
Which is why, you know, Advantage had to kind of take the lead with this whole process, because we, you know, they could share the information with us, we couldn't share it with them, except in an aggregate format.
Okay, great, thank you. One of the questions that came in is sort of general, and maybe you know, maybe Sarah Warren, maybe this makes sense for you as the sheriff's representation on here. But how would you, or what would you recommend if the sheriff's office sort of isn't cooperating and doesn't want to you know, give access or share information, or how would you recommend sort of maybe approaching, you know, the sheriff's office to help work on some of this data piece?
So a couple of the strategies that have worked for us is there's our sheriff and our detention staff, their number one priority is officer safety. And so if there's, and they're not really those touchy-feely types. So if there's a way to approach this in a way that you are helping the individuals within the facility, if they have severe mental illness, there are, if left untreated, they could be a risk to other individuals in the facility, and ultimately it could affect and impact officer safety. So that's one way to approach it. The other way to approach it is if the county is putting a lot of money into some of these services and there's a clear benefit into providing services and looking at data differently in order to achieve some cost savings that are ultimately the benefit of the sheriff and the detention facility. That's another way to spin it. Because I think everybody on this call probably knows that community-based services are not only better for the individual, but they are more likely a lot less expensive. And so that provides some reallocation of resources that could interest the sheriff's office.
Great, thank you. And I didn't know, you know, Evan Evan and Laura, if you guys had anything to add about that or your experience in engaging with your sheriff's office.
Well, I can tell you the initial process and everything was really spearheaded. We were kind of lucky by our Superior Court judge, David A. Sweat, who frankly got sick and tired of seeing the same old guys go in and out of his court system. There were significant costs associated. So kind of taking a page from the folks in North Carolina, we knew anecdotally that there was a large cost associated with these guys cycling in and out. And so we had those discussions, and we had a great relationship with the jail commander and the sheriff's office based on past collaborations with our organization as well as some of the other organizations. So we were having these discussions, and it really just kind of came in informally saying we need to kind of get together and talk about how we're going to divert these guys or get these guys back into the community so they stop taxing our systems, and we can devote our resources towards individuals that really need their assistance. So.
Great. Yeah, absolutely. Thank you. Thank you very much. So that is all the time that we have for questions today. Again, next week we will host the follow-up network call to dive a little bit deeper into this topic. We had a lot of questions that we weren't able to get to with our speakers, and so next week we'll start off with some of those questions and get those questions answered. Again, that's Wednesday, May 17th at 2 o'clock. And then the next Stepping Up webinar is going to be held on June 29th at 2 p.m. As you can see up on the screen, we're going to be talking about question 4 of the 6 questions document, conducting a comprehensive process analysis and inventory of services for people with mental illnesses in your jail. So please be sure to register for the network call and for that and all future webinars at stepuptogether.org/toolkit. We hope you'll join us and come, ready with questions and some feedback on that. I also want to plug a Stepping Up event that'll be happening here in just a few weeks on May 31st at 3:30 Eastern Time. The Stepping Up partners will be hosting a live virtual panel discussion commemorating 2 years of the Stepping Up initiative. Panelists are going to discuss the progress their counties have made as part of the initiative and sort of the continuing challenges and barriers they're facing to eliminate the use of jails as a response to people experiencing mental health crisis. So more of a conversation, no PowerPoint slides. We will be live streaming this event for a wide audience at stepuptogether.org and also on NACO's Facebook page. So we hope that you'll tune in. Again, it's May 31st at 3:30 p.m. Eastern Time. We'll have more information about the agenda and speakers in the next couple of weeks, and you'll also get an email about this, of course, to remind you to put that on your calendar. So we hope everybody will join us for that. Before we leave, I wanted to, get to know a little bit more about you. As you know, we like to do these on the webinars to see who's joining, and we had more than 500 people register for this call. And so, we're very encouraged by your engagement and just want to get some additional information from you. So I'm going to run through these polls really fast. And also, please remember that we'll be launching an evaluation for this call directly after the call. It's going to pop up on your screen. We're also going to send it to you via email with the webinar recording. So we want to make sure that these webinars and the network calls and all the stuff that we're developing for you is helpful and interesting, and that you're getting what you need out of the initiative. So why don't we really quickly run through these poll questions for folks. Let's launch the first one. Great, thank you. And let's go to poll question 2. Okay, question 3. All right, question 4. Okay, very last question. Great. Thank you all so much for indulging me in those poll questions. They really are helpful for us to know sort of who's on the call and who's joining. If you answered what network call, tune in next Wednesday, May 17th at 2 p.m. Eastern. You can register on the Stepping Up website, stepuptogether.org/toolkit, and join us for the follow-up to this call. The contact information for the Stepping Up points of contact are up here on the screen. Please don't hesitate to contact us if you have any questions about the initiative, any feedback, any thoughts, want to share what you're doing. We'd love to hear from you. Thank you to all of our speakers today for taking the time to be with us, and to all of you for being on the phone with us. And please join us on future Stepping Up webinars and fill out that follow-up survey for us. Have a great day.